Thank you, Dr. Martinez, for setting this up, and Dr. Gallagher for pushing along these conversations and getting me to communicate with the ER team about this important topic that we have in front of us, which is how are we going to take COVID intubation precautions for emergency situations, just to clarify and make it distinct from how we're going to approach more elective situations in the operating room. So for COVID intubation precautions for people coming through the emergency department, basically, whether it's a trauma patient or someone that's come in for medical condition or for COVID-related symptoms themselves, we're going to approach these patients in a pretty similar fashion. So we're going to have to be suspicious of everybody in terms of their potential for having COVID. So most of the data that I'm going to present in the discussion here is pretty straightforward. It's just about getting people intubated and how we're going to manage their oxygen supplementation. And a lot of the is based on work that was published out of Wuhan as recently as March of 2020, and then also based upon the ASA's guidelines, which they titled "When Performing Procedures on Patients with Known or Suspected COVID-19 Infection." So sadly, as you all know, everyone is a suspect. And so I'm just going to scroll down here to a picture of a group. Two anesthesiologists in this picture are from Shanghai, and they volunteered to go to Wuhan, and they're pictured here and here helping to intubate this unfortunate patient in January of this year. And they published quite a bit of their experiences. So all patients without an advanced airway, which means an ET tube or an LMA basically, or a non-rebreather face mask, should be wearing a surgical mask at all times. Of course, that's hospital policy. We can't forget about that even when they're in the ER and they're sick, that we need to be sticking with putting a mask on their face, even if they have nasal cannula in place. And we'll talk about other ways to provide supplemental oxygen here. So with regard to supplemental oxygen and pre-oxygenation of patients, certainly those are two different circumstances. For just supplemental oxygen for a patient who is not immediately needing to be intubated, we can take into consideration the virus dispersal and aerosolization that might occur. And this study looked at virus dispersal with different modes of supplemental oxygen administration. And you can see the two major takeaway points from this slide and from this data is that the non-rebreather mask, even with high flows up to 12 liters per minute, the dispersal distance was just about 4 inches or 10 centimeters. So there's not much dispersal at all there to speak of. And then as you go down the list, you can see that simple oxygen with a mask or a nasal cannula, you're getting out towards 20 to 40 centimeters. And then below that, you can see that with BiPAP, you're at 40 centimeters. And then with leaks around the mask of a BiPAP, you can see that you can get jets of air that push the virus dispersal out to 90 centimeters. So that's quite concerning. So when we're thinking about how are we going to provide a patient who has hypoxemia with supplemental oxygen, we want to take these dispersal data into consideration. And we can talk about that further as we talk about pre-oxygenation and also about patients who are needing supplemental oxygen. So patients that aren't in immediate need of an endotracheal tube, of course, you would treat them as you always do and give them supplemental oxygen as is often needed at this elevation. And our goal oxygen saturation is going to be 92 to 96%, as it always is. We're not going to be pushing for higher oxygen goals, as that would, in this circumstance, different than others, would, in addition to be unnecessary oxygen administration, in this circumstance, it increases the risk of virus dispersal with every liter per minute flow that you increase the oxygen flow, with the exception pretty much of the non-rebreather face mask. The non-rebreather face mask really contains the virus particles and the aerosolization very nicely. Now, often, unfortunately, we don't really want to be blasting somebody with 10 liters per minute of non-rebreather face mask for hours on end if all they really need is 1 liter per minute, 1 or 2 liters per minute of nasal cannula. So with nasal cannula supplementation, it's important to use the surgical mask over top. So back to that slide about any patient without an advanced airway, you should consider, let me say that again. Any patient who does not have a non-rebreather face mask or an advanced airway should have a surgical mask over their face to help prevent virus dispersal and aerosolization of virus particles. So the endotracheal tube, once it's in place, is a very good way to contain the virus. An LMA is second best, particularly if there are any leaks. If there are leaks, it could be a very poor way. An LMA might be a very poor way to contain virus dispersal or minimize virus dispersal. And then a non-rebreather is very effective at minimizing virus dispersal without a surgical mask. Our respiratory therapists here at AVH have been using the one mask approach with surgical masks over top, and patients are comfortable with that. There's some anecdotal evidence that it does not increase rebreathing of carbon dioxide. And so I would go down the road of using that surgical mask for any patient with high flow nasal cannula, regular nasal cannula, or the one mask technique, who you do not want to give non-rebreather face mask to for whatever reason. So there are going to be those circumstances where you think high flow nasal cannula with a lower FiO2 is better for that patient. And we have to continually, as you all are, and I am getting accustomed to here, we have to weigh the risks and benefits of lower transmission risk to us, the healthcare workers, versus what's better for the patient. So high flow nasal cannula has some limited data showing that it leads to a lower transmission risk to healthcare workers in CPAP and BiPAP. And that's one reason why high flow nasal cannula is still on our list of things to proceed with first. And as I've mentioned already, CPAP and BiPAP are, I think, larger concerns for virus dispersal because of the inevitable leaks that will occur around the mask. So there's going to be pressure, non-invasive positive pressure inside that mask. And if you get a little leak, you're going to get a jet of virus dispersal that will move the virus to a more distant location and into the room, and aerosolization and droplets will become a risk. So this slide didn't work out too well here. I'm not sure what happened there. So the ASA guidelines for COVID intubations basically say that in each location where an intubation is going to occur, the most experienced airway providers should manage the intubation to minimize the number of attempts. And it discusses that when this occurs in the emergency room or the ICU and not in the operating room, this principle should still apply. So for Aspen Valley Hospital, I think the summary lesson I take for how we should manage those guidelines from the ASA are that we should call the anesthesia providers early so that we can hopefully help you out with these airways. Even if they're not strongly suspected of having COVID, don't have COVID symptoms, they're in for a car accident or a motorcycle accident, until we have better data on what the disease burden is in our community, I feel that it's very reasonable, and the anesthesia group is in agreement with me, that we need to be readily available for you guys for any and all intubations. And I think we historically always have been. I think there is always the issue of the time frame it might take for us to get there. So I think a lot of our availability will depend on how much you want to utilize us and how early you want to call us. And I think we'll have a lower threshold for coming in to help you for sure. And hopefully, if you also have a lower threshold for calling us, we can help you out more often, even for patients that might need a very emergent intubation. So the next slide, the ASA guidelines for COVID intubations. One other very important comment that everybody already knows about, but I'll repeat it here, is that everyone's been saying to prioritize a rapid sequence induction and intubation, and that manual ventilation with non-invasive positive pressure techniques should be avoided if at all possible, and if required, apply small tidal volumes and avoid high pressures with non-invasive techniques. And we'll talk more about that in a moment with regard to pre-oxygenation and the possibility for a failed airway. So let me just scroll through. Let's see. So the COVID RSI checklist medications is the first thing that I have on that checklist of a list of 20 things. So now I'm going to go through the 20 things. So before I get started on going through those things, sort of one at a time, but skipping around a little, I'd like to open it up to any initial questions or comments.
Chris, it's Steve Ayers. I have one.
Yeah.
So I got a little distracted on the face mask part. I thought I heard you say the face mask is low risk for aerosolizing the virus, and then at the end of that, I thought I heard you say something about it was higher risk.
So yeah, I think the face mask, the non-rebreather face mask itself with that design was shown to have very little virus dispersal.
Okay.
And maybe you've seen that chart because it's been sent around a bit.
Yeah. Yeah. Okay.
And the versus a face mask, a different type of face mask, particularly one that you might use to provide positive pressure or CPAP or BiPAP, where you might establish positive pressure beneath the mask and then suddenly have a leak. Those leaks create some high pressure jets of potentially contaminated air.
Oh, yeah. Okay.
Right. So any other comments or questions before I start to proceed through the RSI checklist so that we can come upon the items as they might arise in your process to approach a patient? So we can take, for example, let's say a 55-year-old motorcycle accident victim with a femur fracture that's in the trauma bay. Obvious deformity to the right femur, no other known injuries. He's awake and oriented, but complaining of shortness of breath. And if we just take that patient and think about what we would do in that circumstance, and I know we've been doing as a group, I haven't participated unfortunately, but in the mock trauma process, or if you have another patient that you think might be a better example for one of these different topics, please let me know and we can talk about that. So from this point forward, we'll talk about a patient that is urgently or emergently needing to be intubated. So to start with, we'll start with the medications. You know, we're all going to be getting into our hazmat suits, so you got to be ready and prepare things outside the room. And the trauma team came up with the plan to write them down on the whiteboard, and also the pharmacy has laminated sheets for the different medications that you might choose. And we'll go through which medications are in the RSI box and which aren't. But all the medications you see here on this screen, and I trust everybody can see the same screen I'm seeing, I provided 4 different basic suggestions here for how to proceed. So, or 3 different ways to how to proceed and 1 for how not to proceed. So the 3 positive choices you could make, I think, would be to use a combination of midazolam, propofol, and ketamine. And I picked these medications here One, because I use them on a daily basis, and I think you all do on when you do have these intubations, you're using them regularly. I think pharmacies is familiar with them. They provide a lot of hemodynamic stability when used in combination with each other. And I picked these medications to focus on hemodynamic stability so that whether it's a trauma patient or it's a COVID patient who might be developing multi-organ system failure and potentially having lower systemic vascular resistance or lower cardiac output, and might be susceptible to post-induction hypotension, these medications and these options give you a different range of approach to those patients. So if you look at this patient from outside the room or inside the room and you assess that they're going to be fairly hemodynamically stable, you might focus your induction on propofol still and a little bit less on midazolam and ketamine. Versus if you're pretty worried, maybe you'd go a lot of midazolam or a fair amount of midazolam plus some ketamine. And then if you were really worried, you'd go all ketamine as far as post-induction hypotension. And then avoiding etomidate, I think, is even more important in the current environment because etomidate has been associated with some ICU-related ventilation problems and oxygenation problems, in addition to its longer standing problems with adrenal insufficiency. So in general, I think etomidate's just not as good a choice. One advantage you have with ketamine is that it does have a longer half-life. It's 2.5 hours. So when you give a little bit of ketamine, you give yourself a wider time frame before you need to give a post-induction sedative and keep that patient comfortable on the endotracheal tube while still providing some good hemodynamic stability. With etomidate, the half-life is much shorter. Its amnesic effects dissipate very rapidly. So that might be another reason to avoid etomidate. So I can count 3 reasons to avoid etomidate right off the bat. And I think these other medications have a lot of great properties for amnesia, particularly midazolam and ketamine. Propofol has great amnesia properties, but propofol, of course, has a bit more propensity for post-induction hypotension. But when you choose a good dose of propofol, a moderate dose combined with those other medications, propofol will minimize your intubation-related hypertension. And that's one concern that you might see if you go all ketamine with no midazolam or propofol, is you might get some intubation-related severe tachycardia and hypertension. If you're dealing with a COVID patient that is already febrile, you already might be very concerned about the degree of tachycardia that this 55 or however old that heart is, can that heart handle going from a febrile heart rate of 120 to even higher with tracheal intubation, and that sympathetic surge might not be blunted well at all with ketamine. So that's where I think considering midazolam and propofol to blunt the tracheal intubation hypertension while being ready to deal with the immediate effects of post-intubation hypotension is important to consider. So moving on from the induction agents, along with your induction, you should plan your paralytics. And anybody feel free to interrupt me if you think you have a comment or question. Go ahead.
Oh, hey, Chris, this is Mike.
Hey, Mike.
I was just gonna say it seems like almost of this small number of patients, but I think I've had 3 that we've intubated, and all 3 of them have become hypotensive post-intubation just because, I mean, I think we're so sparing with the fluids based on the recommendations for COVID that they, with the intubation, I think they get poor venous return, and almost all of them have gotten hypotensive, and they've needed fluid boluses and pressors, at least the 3 that I have been involved with. So
I agree. So that's part of the initial assessment is this patient here needing to be intubated because uh, of a non-COVID related reason as the more predominant reason for being intubated, and therefore you might be less suspicious of post-induction hypotension. One of the COVID patients I was involved with was fairly hypertensive for a good hour after intubation before revealing that propensity for hypotension. So it can be a difficult balance to find whether or not I think you're worried about tracheal intubation related tachycardia and hypertension versus the post-induction hypotension. And later in a few slides, I'm going to go over pressors that you should bring into the room with you when you're making plans. So we're still on the first step of the RSI sequence, and this is for any emergency, not just a COVID patient, but anybody in the ER who has any reason to get intubated. And right now, we're just taking COVID precautions for all of them. So I think the COVID RSI medications are a good place to start. If you think that the patient doesn't have symptomatic COVID and you want to go all propofol and no ketamine and no bedazolam, I think that's reasonable for a hemodynamically stable patient that's there for a different reason needing to be intubated. But I think most patients intubate in the ER that I've been involved with do have some concern for post-induction hypotension, whether it's hypovolemia or cardiomyopathy or reduced systemic vascular resistance. So I think we often see reasons for shock overlaid upon a normal amount of post-induction hypotension were the patient not also severely ill. So we'll talk about pressors in just a second to that point, Dr. Grauka. And so, because that's a very important thing to consider during all of this. And then we have paralytic induction agents. And when you're picking your paralytic induction agent, you also want to pick your post-intubation paralytic agent, because you don't want to have the patient after succinylcholine then reach up and extubate him or herself. So we're going to keep these patients well paralyzed for a few reasons. One is, at all costs, the tube has to stay in so we don't contaminate everybody. Number two, if you have COVID-related lung disease, ventilate them as well as possible. These patients might have post-intubation hypoxemia that is very difficult to treat. So we need to optimize their ventilator assistance, and the best way to optimize ventilator assistance and control their ventilation initially is to have them completely paralyzed. So rocuronium is a great choice. You do have to be patient if you want to optimize your intubation readiness and your intubating conditions, as they're called, need to be optimized so that you minimize your number of attempts. So one great way to know when you should be intubated is by using succinylcholine. If you use succinylcholine, you see fasciculations, you know the patient is maximally relaxed. Of course, succinylcholine has downsides, like it wears off in several minutes. So you need to be prepared with your post-intubation paralytic agent and ready to go. So as you can see on this slide, if you use succinylcholine, be ready to give some vecuronium. And the reason I pick vecuronium here is to preserve our supply of rocuronium. So if you've used rocuronium up front, it's a great induction paralytic, much better than vecuronium. So if we're going to do some long-term paralysis of the patients, I think we should all be cognizant of our supply of rocuronium, move away from rocuronium for long-term needs, and use vecuronium in those circumstances so that we preserve rocuronium for its utility as a very good option for rapid sequence induction, particularly if we get to the point where succinylcholine for a specific patient isn't a good option, or we're running out of rocuronium because of supply chain issues. So then the next medication, so we're already in the process of planning our intubation. I think we should be writing on the intubation board, or on the whiteboard, excuse me, not just our intubation drugs, but our post-intubation drugs. And our post-intubation drugs are going to include the post-intubation paralytic if needed, if you need to give vecuronium because you chose succinylcholine up front. If you chose rocuronium, you can just cruise on the rocuronium probably for 90 minutes. So the post-intubation sedation is important though. If you have that patient paralyzed with rocuronium or vecuronium, but you haven't given them that much ketamine and they're starting to wake up by we might show you those signs by being hypertensive and tachycardic. So you want to be ready to treat for an appropriate amount of sedation and comfort for your patient with analgesia and sedation potentially with benzodiazepines or opioids. I'm proposing that a nice approach is to use Valium or lorazepam because of their hemodynamic stability. They're much more hemodynamically stable for patients with much less hypotension than you'll see with a dose of fentanyl. It might result in a similar reduction in agitation or tachycardia. With the benzodiazepine, you'll see much more stable blood pressures, particularly compared to propofol or dexmedetomidine. So if we're talking about a patient that might actually have COVID-related disease, cardiopulmonary disease, a propofol infusion and dexmedetomidine infusion are going to get you into higher doses of pressors, inevitably, compared to Valium. Valium's nice because of how infrequently you need to dose it. It's low maintenance and not labor intensive for your nursing staff. So it's going to hopefully decrease their need to be in the room, potentially changing pump levels and changing pressor levels. So for me, Valium's a top choice. If a COVID patient or any patient really that you don't need to wake up soon. If you're okay with them being, not extubated till tomorrow, I'd say Valium's a great choice, and it allows you hemodynamic stability. You can be assured they're not going to remember much for the vast majority of patients unless they have a very high alcohol tolerance. And then you just redose them more frequently or add an opioid. A propofol infusion also adds to complexity for transfer of the patient. Any infusion we use can add to the complexity for transport to the flight team. A one-time dose that just hangs out for many hours, like Valium, rocuronium, vecuronium, those medications I think are going to be favors to your transport team. And additionally, it's going to do a favor to our supply and stock of propofol. If we start doing propofol infusions for everybody, we're going to run out of propofol pretty quickly. And we don't know in this current climate and this economy what our supply chain is going to look like. Right now it looks good, but I'd say we try to keep it looking good by making good choices with regard to utilization. So post-intubation pressures, again, pick these early and take them into the room with you early so there's no rushing or less rushing if possible. Have the norepinephrine drawn up, ready to go in a syringe with boluses and as an infusion if you're really concerned that this patient might have sepsis, cardiomyopathy, or other reasons that you don't want to aggressively volume resuscitate the patient. If they're a trauma patient, obviously you might be, the post-intubation pressor might be much less indicated than blood products. But nevertheless, in this era of COVID, we need to consider that it's possible that a patient coming in with a seizure might have underlying COVID-related cardiomyopathy. So I think having the post-intubation pressors for every patient, including for trauma patients, is going to be more important than the past. And we might feel less condemned for using a pressor in a trauma patient for whom we're suspicious of COVID than we would be if they just without this COVID suspicion, given that for trauma patients, normally we would try to shy away from pressors and move towards volume resuscitation as the first.
Chris, can I say something? It's Katie.
Yeah. Hi, Katie.
Hey, hi. I just wanted to mention, with this is kind of going back a few minutes, but with the intubation, if you use vecuronium, you have to reconstitute it.
Right.
I think if you're not familiar with that, you have to get familiar with that. You dilute it up and then you give it.
So the
So
vecuronium provided in the RSI kit,
yeah.
and unfortunately the RSI kit slide that I put on here got cut off a little bit. I think when I moved the PowerPoint document around from a few different locations, it cut off some of my slides. But the sterile water is included in the RSI Med Kit contents. Number one, so that you can reconstitute the vecuronium with sterile water or normal saline or LR if you want to. It doesn't matter. And I don't suggest, just to go back up to I'm going to slide back up here to the intubation paralytics.
Mm-hmm.
I don't suggest that you choose vecuronium as your first line agent, but as Katie's suggesting, you use succinylcholine, you better have that vecuronium already reconstituted, and that's an excellent point as far as being prepared.
Yeah, so, just a little awkward, and if you're not used to using it, it might, if you're in an emergency, you might not be, I'm just bringing it up as an aside, that's all.
Yes, that's a good point. Anybody who might be assisting with the medication preparations, if the intubating provider chooses succinylcholine and vecuronium as their follow-up medication, it would be better to get that vecuronium ready before they go in the room and have that reconstituted. So meds that you might need for the RSI that are not in the RSI kit that I've mentioned already and were on these other slides are important to consider are the Valium, Ativan, fentanyl, dexmedetomidine, infusion doses of propofol, norepinephrine, normal saline syringes for flushing. Those things are not in the RSI kit, but they are readily available in other Pyxis machines in the emergency room. During daylight hours, by all means, utilize the pharmacy and the pharmacists and the pharmacy techs to help you. After hours, when the pharmacy is not in-house, please call on your house supervisor and critical care nurses and other nurses with critical care skills to help you get these medications ready and go through the checklist, the whiteboard, write them down on the whiteboard. So I'm going to go back to the COVID RSI checklist here real quick. So we've only gotten through number one so far. So I'll try to speed up the rate at which I'm discussing these things. So medications were first, RSI equipment is next. So here we are with a COVID RSI checklist. Number two, RSI equipment. Pick your stuff, get it ready, take it in the room. So pick your endotracheal tube size. And here I'd like to emphasize something that went back and forth in an email today as well with Dr. Ayers and a number of other people as a result of, partially as a result of the trauma, the mock trauma process. I think it'd be good for us to, in addition to writing down the meds we're going to use, the weight of the patient, whether or not they have allergies, we should also write down the patient's height and start thinking about what our endotracheal tube depth is going to be. And you can go with the guesstimation that most anesthesia providers use every day when we intubate, is we guesstimate, we start with 21 to 23 for a male, 19 to 21 for a female at the front teeth. And then we estimate, depending on when we do the intubation, how far down was it before we saw that cuff go through the cords, and then and also you look at the length of the neck and the height of the patient. If they're 6'6", I'm probably going to go 23 to 24, 5, like all of you.
Hey, Chris.
Yeah, Mike.
Well, I just wanted to emphasize the height of the patient is so important right now because we use it to determine their tidal volumes, and we're using really low tidal volumes for the ARDS protocols for the COVID patients. So if their height is off, it's been throwing off our tidal volumes. And so we've had a couple of patients who are probably on lower tidal volumes than they should be.
Got it.
So that, yeah.
And that does come down to also calculating the ideal body weight is what we need the height for. So I think that's really important, and we're going to talk about that as well in just a second. And so you want to have readily available this equipment. Pick your endotracheal tube size. I think if you think the patient's really sick and is going to have COVID lung disease, you're better off going with a slightly larger tube to reduce airway resistance. But you guys all know about picking tube sizes, so I'm not going to talk about that today. But what I did want to talk about is just if it's going to make you more comfortable, write down the ET tube expected depth on the whiteboard before you go in the room, because there's going to be a lot going on in there. It's going to be hard to communicate with the respiratory therapist with the PAPR on. The less you have to say to each other, sadly, or the more that you've predetermined as a baseline might be helpful for problems later on. And also have readily available equipment for a possible failed intubation, because with the PAPRs on, it might be harder to communicate. It'd be better to have some of these disposable items readily available. So the next thing we're going to go to on page 1 of the COVID RSI, it's not really different pages, but I just split it up here for visual purposes. I'm going to skip down to number 7, which is prepare the ventilator setting. So this is another thing that I think from a process standpoint, you're using the whiteboard, shout out the vent settings so that your respiratory therapist can type in the vent settings before you've intubated. So once you get the tube in, you're going to go straight to the ventilator, potentially without even using the ambu bag. And we can talk about that in a second and why that might be beneficial if you can avoid using the ambu bag if you haven't pre-oxygenated with it. And I'll tell you why in just a moment. But so you pick your vent settings, write them on the board with the ideal body weight. You need the patient's height to calculate that, and have somebody calculate it. Say I want 6 mLs per kilo ideal body weight, and go down the list of what you think might be better with the PEEP, depending on their pulmonary versus their cardiac condition, and so forth. I did want to just for a moment go back up to, I forgot what I was thinking, never mind. So on to the next thing. You've picked your ventilator settings, you tell the RT, they're going to get everything ready. So as far as the ventilator circuit with capnography, can you all see this whole slide? Is this silly thing on the side in your way? Here, let me try to move it. Okay. So the COVID RSI checklist continued. Now we're on number 8, 9, and 10 of the RSI checklist. So respiratory therapy is going to have the ventilator ready to go with inline suction, capnography, and possibly the bidirectional viral filter. We got to talk about that for a moment and whether or not we want to use that viral filter. So I don't want to get too much into that right now. We can touch upon it in just a moment. So the next step is pre-oxygenate. So you have options. If the patient already had a non-rebreather, that's probably a great choice. Just have them take some deep breaths if they can. If they're already on high flow nasal cannula, crank it up to 100% on the oxygen and just keep it going and use that as your pre-oxygenation. If you do choose to use the ambu bag, we have a head strap that fits on the mask in the RSI kit so that you can use all 4 straps. So there are 4 straps on this head strap. And it's a little intimidating to the patient if they're wide awake. You could give one a Versed and help them out with that if it's bothering them. But you want to avoid mask leaks. So if possible, so in the RSI kit, you can supply the ambu bag with oxygen via the normal route, or we have a PEEP adapter on there, and you can do the oxygen flow through that. You don't use both, you use one or the other. So if you use the PEEP adapter in the RSI kit, you really have to have a good mask leak, because as soon as you use PEEP, you're applying non-invasive positive pressure, and you're doing the thing that the ASA asks you to minimize, which is avoiding non-invasive positive pressure so you avoid unexpected leaks out the side. Now, for just a moment, I need to back up and say, while you're getting the pre-oxygenation in place, the COVID tent needs to be in place. So you got to put the COVID tent up and have your RSI stuff ready. So you need to have your video laryngoscopy ready. Video laryngoscopy is recommended right now so that you can be farther away from the patient. So the COVID tent is this device that maybe a lot of you have seen photos of this. and it's very handy. We tried the COVID intubation box, problems with that. Here are two versions. You can see one version on the left is with the operating room table, and then the version on the right is a patient stretcher you might see in the ER without the mattress on, though, unfortunately. So I'm so appreciative to John Albers and Abel and Josue for building this, and to Dr. Gallagher for asking them to build it and really pushing for us to get this process started. Dr. Franzi's used the COVID intubation tent. Great. In the picture on the left, you can see he used it with a C-arm drape, which has elastic around the bottom of it. And then on the right is the clear plastic drape from the hardware store that we're putting in the RSI kits. The RSI kit also has surgical drapes that you can put inside of this device, so that hopefully the plastic doesn't lift up too much, because you want to keep the plastic as low down to the patient mattress as possible. In the picture on the right, you can see how the hoop of the COVID tent is above my head. In the left, where Dr. Franz is doing it, he hasn't lifted the bed height up high enough. So the hoop is going to hit him right in the forehead when he's trying to do his intubation. So you want to make sure that the bed height is high enough for even somebody as tall as Dr. Balco, that the hoop isn't in your line of sight. So you got to raise the bed up to a comfortable level, approximately so that the patient's forehead is at the height of your elbow. And that's good intubation technique anyway, and better for your ergodynamics and the longevity of your back, that I don't know that we always focus on, but now we need to focus on it so that the plastic drape stays in place and we're not blasting virus around the room unnecessarily. So use the surgical drape clamps that are in the RSI kit, if you would, to help secure the drape to the sides of the hoops of the tent. So I think that the plastic drape that's in the RSI kits is really sufficient, and we're going to promote that you guys just use that in the ER. If you really want the C-arm drape, we have them available in the OR, and you could grab one of those if you have time. But they're a little bit costlier and less available. So I'm not sure how much we're going to get to use them either. But the clear plastic drape literally costs a couple dollars or less. It's readily available. I think it's going to work really well. So the RSI checklist continued. Now we're on, so there are 20 items on the RSI checklist. I'm on to number 11 here. So we're halfway there. So you've intubated the patient, and now it's time to ventilate them. So there are two approaches here. If you've already used the ambu bag with, and you were pre-oxygenating, I failed to mention this before, you should have been pre-oxygenating with the bidirectional viral filter in place. So we're trying to avoid disconnects. And the way to avoid disconnects is to make sure your stuff's all ready to go. So if you connect the ventilator circuit with the viral filter in place, at some point down the road, somebody's going to have to take that viral filter out of there in order to suction the patient's endotracheal tube. So just be sure if you do any disconnect, you have the COVID tent still in place. And if you use the ambu bag, you should always have the viral filter right there on the endotracheal tube. So one option is that if you've pre-oxygenated with the non-rebreather face mask and you intubate and you haven't yet touched that viral filter, you can go straight to connecting to the ventilator circuit that the respiratory therapist has prepared with the inline suction and capnography without the viral filter, because they have another viral filter, a unidirectional viral filter on the circuit distal from the patient. So the viral filter, the bidirectional viral filter on the endotracheal tube is most important if you need to transport the patient and you're going to be disconnecting. Say if you're going to fly the patient to another facility, having the viral filter is going to be really helpful. unless you have to do inline suction. And then you'd have to take the viral filter off anyway. But if you're going to transport them and have a lot of disconnects, if you transport them to the CT scanner or to St. Mary's, having that viral filter in place is going to protect every provider that's subsequently involved in a disconnecting procedure. So establish the correct ET tube depth. We talked about that. The one thing I didn't mention about the ET tube depth that I said in the email I sent is that there's a great app called MD Calc. You just type in endotracheal tube depth and you type in the patient's gender and height, and it'll give you the. So, you know, if the house supervisors or respiratory therapists or anybody want to, or any of the ER docs want to, you know, have that app ready to go on your phone or the web page ready to go on your browser, you can quickly type it in and it'll tell you the depth, and it's just one less decision you have to make potentially. You establish the correct depth in advance, but then once the endotracheal tube is in place, then you want to confirm its location. It's going to be hard to confirm the location without using auscultation. So you might need to ask somebody to listen. That can be hard if you learn. So that's why establishing the endotracheal tube depth is so important in patients, is we can't just grab a stethoscope and listen. So it's really hard. So you really want to guesstimate or estimate accurately, calculate the right depth right out of the gate so that you can be very confident that you don't really need to listen to bilateral breath sounds if you observe bilateral chest rise. Your ventilator isn't giving you indications of high plateau pressures and a main stem intubation. And then lastly, the ballottement of the endotracheal tube cuff in the sternal notch. And if anybody would like to learn how to do that at some point, I'd be happy to show you. It's super easy. You just hold the cuff between your thumb and forefinger and then press in the sternal notch. If you can feel the balloon in this hand, in your right hand, bouncing up and down on the cuff when I press with my left hand on the sternal notch area, then you know your tube is not too shallow or too deep. And that's a great tool, because what do we want to get a post-intubation chest x-ray? I'm not sure. We'll talk about that in a moment. So the RSI checklist continued. Number 13, 14, 15, and 16 on this list are to check the hemodynamics, place an NG tube, administer sedatives, analgesics. We've already talked about that. Continue checking the blood pressure frequently. During the intubation, and I have this on the RSI checklist on a different slide. I'm not going to go back to it, but I'll mention that I have included there that you should put the pulse oximeter on audible for all patients when you're doing intubations, particularly in this scenario where the PAPRs are on. You should turn it up really loud. And number two, you should put the blood pressure on every 2.5 minutes and not back it off to every 5 or 10 minutes until you're satisfied that the patient is relatively stable. So during this process, one of the most important things we're going to come upon is number 17 on the RSI checklist, which is to take off your PPE correctly. So I didn't go over putting on the PPE correctly, and maybe I should have done that more closely. But putting on the PPE correctly, for the intubating team, you're going to wear a PAPR if it's available. If it's not available, you're going to use the N95 mask with a face shield. Anybody going in these rooms until the airway is secured and it's been many minutes afterwards should not be going in the room unless you have an N95 mask on. So 30 minutes after the intubation is a reasonable time frame to think that you should be wearing an N95 mask in that room if there have been no further procedures on the patient that might aerosolize virus. So the COVID tent is definitely going to help minimize aerosolization in the room. And we do have to take into consideration our N95 supply and weigh that against the personal risk with each exposure and when and where to use the N95s. So that's often a judgment call depending on the nature of the procedures going on in the room, the risk of the patient, and the availability of PPE. Having said that, the intubation team that's in there immediately is going to use the intubation tent as much as possible to really minimize exposure outside the tent. And so I'd like to go back to the comment about I'd like to go back to the tent for a moment. When you're using the tent and you have suction available for the patient's airway, it's good to just leave that suction in the tent and leave it on high all the time, even after you intubate, so that the suction is pulling any virus out from within that environment and out to the suction canister, and hopefully neutralizing that virus in that closed container as much as possible from the staff. So I think we're going to be putting positive pressure into the tent during pre-oxygenation, and then there's going to be a closed airway without any positive pressure or negative pressure in that COVID tent, unless you leave the suction on. So leaving on the suction is going to create some substantial negative pressure within the tent once you've stopped doing the pre-oxygenation effort, and that will help further minimize any leaking of virus particles out from underneath the tent. So that's one other suggestion that I haven't written down in this PowerPoint presentation that I think is an important consideration that Dr. Franzi and others have really promoted, which is leave the suction on inside that tent the whole time. It's cheap, it's easy, it's only gonna create preferentially a small micro atmosphere that's negative pressure. And that's only gonna help everybody reduce exposure. So then next on the RSI checklist, taking your PPE off is critically important. When you put the PPE on for the airway management, at least double glove, probably triple glove is recommended, 2 gowns for the intubator. And you want to consider whatever goes in underneath that tent is contaminated. So as soon as you're able to take off those exterior gloves and the exterior gown, because you're contaminated, you've contaminated that entire gown once you put your arms underneath it. So as soon as you move away from the bed and are done with patient care, you can take off the outer layer, second gown, and still have another gown underneath it, and take off the outer gloves, the third layer of gloves, or second layer of gloves if you're comfortable, if you prefer just to use 2 layers. And then underneath, you still have another layer of gloves and gown. And be cautious with your wrists. Some people are taping the gowns to the gloves, and I think that's a great idea. You don't want to get exposure anywhere. And when you're using the PAPR, you don't want to leave your neck exposed. We have shrouds that maybe some of you have seen. They cover the neck very well and go down, down to your torso. And I think when you don't use the shroud that goes down to your torso and you just use the device that contains your head, your neck will feel very exposed. And so if you do that technique, just make sure you wash your neck as quickly as possible as well. And you have to then be concerned about having contaminated jewelry or your, undershirt or whatever else. So, I think wearing a lot of gowns and covering up your neck as much as possible would probably be better for reducing your exposure. And we do have substantial numbers of shrouds. So do we want to get a portable chest x-ray? That exposes the radiology techs. It's opening the doors, it's bringing a big machine in, and you have to wash that off. Is a chest x-ray necessary? I think that's a judgment call and might depend on the patient concerns, whether or not you're concerned about your tube being too deep or too shallow, things like that. And on another slide, I wrote put in an NG tube. I think an NG tube is probably better if you think you can do it without creating bleeding. And a lot of people are proposing that we use point of care ultrasound to help look at pleural sliding, to look for bilateral insufflation of the lungs. And if that's a skill that you have, I'd suggest that you might want to use it in this circumstance if the ultrasound maybe is already in the room. Bringing a big machine like an ultrasound into the room, if it's not already in there, I don't know how much of an advantage that is over just getting the chest x-ray. But if you already did a fast exam, you know how to look for pleural sliding. Maybe that's a good option for that approach. You can also look in the sternal notch with the ultrasound to look for the endotracheal tube cuff air there. And that's something that I think many providers are using because of the difficulty with just using the stethoscope. So let's see. So I have a slide just on minimizing circuit disconnects. I've talked about that quite a bit. One concern with the bidirectional viral filters is simply that there's a shortage of them. So if we run through these in the next 2 weeks by using 6 of them, we might not have any more. So that's one reason why I suggest that in the OR, we're not going to use them unless we need to. And that in the ER, if you don't think you're going to need to disconnect the patient soon and ventilate them with an ambu bag, and you can go right to the respiratory therapy ventilator circuit, to the ICU vent circuit with that unidirectional viral filter, that's a good option for conserving our bidirectional viral filters if you were able to leave that viral filter outside the room and not bring it in and contaminate it. So that's the one caution about the bidirectional viral filter that would be so useful. I'd like to use them on every patient all the time, but the reality, unfortunately, is that we don't have access to an unlimited supply of those bidirectional viral filters. The unidirectional viral filters come with the circuits in many cases for both anesthesia machines and for the ICU ventilators. So with suctioning, you want to use the closed suction, ASA guidelines on that. And with that, I think that concludes my comments. Does anyone have questions or concerns, comments for the group?
Hi, this is Kim. I have a few things.
Yeah.
Sorry. On the C-arm drapes, if you feel like we really need to stay as standardized as possible. So my concern was saying if you decide you want that instead of the tent drape, then I've got someone trying to run and find it at the point of intubation procedure. So I guess we really need to make a decision. Is that just for the OR and what you're doing? Because it makes sense for pulling it back in the OR so you have it for extubation and stay with our tents in ER and ICU.
Yes, I agree with you, Kim. Everywhere but the OR should use the drape, the clear plastic drape that is not the C-arm specific drape. I agree with you. That would create unnecessary confusion. We have no indication that one is better than the other. In fact, my bias is that the clear plastic drape with the surgical clamp is probably better.
Okay, and then the filter placement on the inline suction catheter, we're actually putting it on that corrugated tubing, so it is blocking anything going out. And I guess I feel like the safest practice is to continue with that closed suction hooked to the ET tube with the filter on the corrugated tubing that's part of that.
Okay.
If we're a method of moving that filter onto the ET tube, I think that potential issues with secretions and not being able to control that will be an issue. So we weren't sure. We got Don and Bo and I listening, and we were kind of thinking that's what you were saying, is to put that filter on the ET tube directly, and we're not.
Right. That's what I'm saying, particularly for a situation where we're going to want to use the ambu bag to, like, let's say we're going to intubate and go directly to the, like, that would be a great situation to have the viral filter on the tracheal tube. And
Okay.
not use your ventilator, not use the ICU ventilator. If we're going to use the ICU ventilator, I agree with you that using that bidirectional viral filter is going to get in the way of suctioning. But if we're going to forego the ICU ventilator and go straight from having intubated, just manually ventilate the ambu bag, and then go to the operating room for surgery, then the bidirectional filter, I think, is critical for everybody's safety. Does that make sense
Okay,
to you?
that makes, yeah,
Yeah.
we
Okay.
agree with that. We were just kind of confused as where you were going with that on
Yeah,
everything,
I
so
think
we just
those
want.
are, yeah, those are the two scenarios that I envisioned, was either going directly to your ventilator, or are we going to be going directly to, say, the transport ventilator? Maybe the transport team's already there. In which case, maybe we'd want to use up that bidirectional filter until we transfer to their ventilator. If we're just
Right.
ambu bag. So I think if your focus is a bit on post-induction ambu bag ventilation, then the bidirectional biofilter is almost a must. If your primary mode of ventilation is going to be going with Kim and her team and our team manage the ventilator, then that bidirectional filter, like you said, is going to collect secretions, get in the way of them doing suctioning, and just create further disconnect that could be difficult for other team members down the road as far as their exposures. That viral filter might be great for reducing your exposure right then and there, but down the road, it could create more problems than it's worth. And so particularly while you have that tent up, you've got this micro environment that really is protecting larger environments. So if you can optimize the setup for best utility, the tent is down, that would be ideal. So get that patient ready coming off.
Okay,
You have another
one last
Yeah.
one.
Great. Good
Okay,
point.
you talked about the suction under the tent,
Yeah.
and just wondering, are you envisioning that with the yanker section that's hooked up for the intubation process?
Yes. Yep. And then once
Okay.
the process is done, you could just disconnect the yank hour so that the suction process is stronger. So it's not as flow limited by the yank hour. So that's,
Okay.
no. And I have no data to support that. But it
Right.
just
And there,
makes sense.
we have to put it on the patient on the closed suction system to suction, but
Ah,
otherwise we could.
well, then that's more important.
Yeah.
But we do need to probably have the two suctions available, right, as separate systems. Like one suction for
Yeah.
the hour and one suction for the circuit.
Yeah, we can do that. So no problem.
Yeah. Okay, good. Yeah, because if we took the suction off the circuit, that would constitute a disconnect.
Hey, Chris, I have a couple comments.
Yeah.
So because most of our intubated patients in the emergency room are going to get transferred out and not go to the OR or the ICU, wouldn't the safest thing to do contamination be to pass the endotracheal tube, followed by the inline suction, followed by the viral filter? And that way the viral filter is not in the way of the suction. And when you transfer from our vent to the helicopter or EMS vent, you don't risk any contamination during the disconnect?
That makes sense to me. Kim, what do you think about that?
We already have all of the systems set up exactly like that. So when
okay.
we have that vent ready to go, the inline closed suction catheter has the bidirectional viral filter on that's hooked to our circuit to the vent. And then when we transfer it to the transport team, we will only disconnect the circuit. We will leave the filter in line attached to the closed suction because the team will want to use that closed suction device as well. So the circuit connection points are interchangeable.
Right. So I had I think on this other slide, I had the order wrong for.
Yeah, I think endotracheal tube, inline suction, then viral filter. And we'll probably use that in every single ED intubation because most of them get transferred out.
Yeah. So Kim, do you know, are we still just with 6 of those in-house? I'm not sure.
Oh, the filter count, they did get some more. So that's looking better. And I believe that Pete thought by the end of this week, we would have 120 at least
Oh, okay.
in our.
Okay. Because the ASA, or the Anesthesia Patient Safety Foundation, recommends that we use those filters if we have them, even for elective cases, in addition to the export limb of the breathing circuit unidirectional filter, and you use both if you have the supply. So, but if you don't have the supply, they say that the one filter on the expiratory limb is sufficient. So Kim, when you have my impression was that you were using an expiratory limb unidirectional circuit in addition to this bidirectional filter. Is that right?
Yes, we're putting one on the expiratory port of the vent and as well on the inspiratory side of the vent. That's just how we've always set our ventilators up. So
Yeah.
there's a protection on the ends of that to connect to the ventilator.
So let's see. So if we're going to go, so for some intubations, let's say we're going to intubate and go directly to the OR, we might skip the inline suction theoretically, but I guess we could use it also and then use it in the OR if we needed it. So I think, to Scott's point, we would go capnography, then bidirectional filter, and then inline suction, and then endotracheal tube. And then when we disconnect and go to the OR, we could keep the inline suction and the bidirectional viral filter for transport and use the ambu bag.
And actually that ventilator that we hook almost everybody up to, the LTV in the ER, is a transport ventilator. We can disconnect and hook to a tank, and it can actually stay connected to the patient to the OR as an option as well.
Well, that's a great option, because we never know precisely how long it will be from intubation to when we're ready and the patient is ready to be moved to the OR. So having that transport ventilator for those circumstances where we're anticipating we're going to go intubation to the AVH OR, and that probably is going to be less common in the emergency room. I foresee that being more common, that we might intubate someone in the PACU isolation room if they're stable from a cardiopulmonary standpoint and they're going to go for surgery and we think they're high COVID risk and they're going for urgent or emergent surgery. We would need to discuss whether or not it was wise to use your trauma room or to transport the patient to the PACU isolation room for that intubation event. So that's something we could think about, Scott. If it's, a femur fracture needs to be intubated, they're already in the trauma room, we probably should just intubate them there, right? Since they've already contaminated that location. Okay. Scott, what else? You had some other comments?
I just wanted to make a push for simplification. I think in the combative trauma patient, ketamine is really the way to go.
Okay.
Especially if you're having trouble with pre-oxygenation, you can give them the ketamine and sort of do the DSI, the delayed sequence intubation, where you're letting them breathe on their own. They're relaxed. You're not having to BVM them to get them to an optimal oxygenation before you intubate. So I think I don't know, we're certainly willing to call you guys, but sometimes when things happen quickly, I think ketamine and rock is probably the simplest for simple-minded ER docs.
Yeah, I think it's a great option. I think it gives you great post induction amnesia. I think it gives you great in intubation hemodynamic stability and post intubation stability. So it's a great choice. I think I was hesitant, I think, more about ketamine being the only choice for febrile COVID patients who are already tachycardic. And what that approach might cost you in terms of tachycardia. But I think for, like you're saying, if it's a combative trauma patient who we're just taking COVID precautions on because of their potential low viral load or asymptomatic viral load, yeah, ketamine's an awesome choice.
Hey, Chris, it's Chris Martinez.
Hi, Chris.
So in the patients that that we've seen in the ED, at least the patients that I've seen in the ED and pre-hospital wise, and actually it's been pretty well studied, that even if they're tachycardic and hypertensive, even when they're febrile, once they receive ketamine, almost invariably that tachycardia and hypertension decrease if they're really elevated high. Now, I can't say that for every patient, but it seems that just getting them under control decreases that sympathomimetic response. So I'm sure that it is a consideration, but maybe not as much a consideration as has been thought of in the past. I just wanted to point that out. I do have a question. One of the nurses asked me last night. They asked me if we have a neutropenic patient, which traditionally are kept in a positive airway pressure room, do we treat them any differently? And I didn't know the answer.
Well, I guess my consideration taken, I think what I'm thinking is, and maybe Dr. Goralka would weigh in on this, but I think, you know, at what risk are we putting the patient to follow through on these COVID protection strategies for everybody else in the ER, particularly if they're unknown COVID? So if they're very sick and septic, neutropenic, you know, maybe we need to prioritize the patient over the risk of potential contamination with regard to which room we do it in. Mike, what do you think about that?
I mean, I guess it depends on how high of a suspicion the COVID would be. I think if it's a low suspicion for COVID, you probably wouldn't have them in a negative pressure room necessarily. I don't know. If it's a high suspicion, I think probably would be best to have them in the negative pressure room. I think it's a sort of a judgment call.
Okay, thanks. I just hadn't thought about it before until I was asked that last night. Chris, I just had a couple of general comments to make real quick.
Yeah,
Steve was
Chris, before
about the non-rebreather earlier, and I just wanted to point out that both of those ports on the non-rebreather are covered adequately by a surgical mask. So that also helps with any decrease of viral spread in utilizing that over nasal cannula. I also wanted to point out that I've personally seen in our emergency department in the past week an increasing use of nasal cannulas again for patients that I felt didn't need to be oxygenated. So we all need to be aware of that. For example, patients that come in that feel short of breath but have normal O2 sats, or somebody that gets put on oxygen because their O2 sats 93%, or because somebody's tachypnic in the 20s, or because they're complaining of chest pain but satting normally, or they're have some tachycardia. So I just wanted to point out that I'm seeing this happening again because, you know, it's just such a normal thing for us in normal times. So we just need to be aware of that. And then the third thing that I'm seeing a drop off on in the past week is masking all our patients in the ED. And so it seems again that we just need to be aware to continue to ask for all our patients to be masked until we decide otherwise. So those are my general comments.
Yeah,
Chris, thanks for the presentation. I thought it was really good.
Could I just comment, Dr. Martinez, that as we are preparing to start elective surgeries this Friday, and the community is, you know, going to reduce restrictions on May 9th, I believe, and then other counties and the rest of the state have already reduced restrictions. We're only going to see increases in the COVID community burden here, I think, and so in the operating room area, I can tell you that we are emphasizing, 1, no visitors, and 2, a mask at all time unless you have an advanced airway in place. And if you do get a visitor because you're a pediatric patient or a disabled adult, then everybody gets a mask. And we're taking, so I would appreciate, and I think your concern about that, that we stay vigilant about that in the emergency department. I also agree that this is a good time to minimize unnecessary oxygen administration because of the virus dispersal risk. But in regard to that, with the non-rebreather, you know, I don't think that if you go to 2 liters of nasal cannula with a face mask, you necessarily want to go to the non-rebreather just to reduce the COVID contamination risk, simply because that can just be too much oxygen for a person. You know, they don't need to be blasted with that much hyperoxia. I think there are some downsides to that. With regard to what you said about ketamine, I appreciate the data that you referenced. And I think that it's important to keep in mind with regard to your preparation and your thoughts about the patient, just that patient responses to intubation drugs, the intubation stimulation, and then the post-intubation lull in stimulation can be quite variable from patient to patient, and just got to be on your toes, I think. And I guess with the COVID patients I've been involved with, I have struggled a bit with managing tachycardia to some degree that I haven't seen as much of historically prior to this era. Not that it's been many patients, of course. So I've got an N of 2, but that is a consideration. But thank you for your comments, Dr. Martinez. Did someone else have some questions or comments?
Hey, Dr. Beck, it's Steve.
Hi, Steve.
Yeah, a couple things. One thing about regarding the tachycardia, hypertension, I think it depends on the etiology of it, but at least with excited delirium patients, which will have both and sometimes fever, the ketamine does decrease all three in those patients. May in hyperadrenergic states. The other thing I think might be a paradigm shift. It might be going back in time, but your very first comment at the beginning of your talk about the most experienced person, and I think there's not agreement among our group totally, but certainly I think we should at least consider adding the anesthesiologist or the anesthesia provider to the full trauma team activation, because if you had mentioned the trauma patient, and right now you guys don't even know when we have a full trauma activation unless you're in house and hear about it.
So that would be easier actually than you imagine, because it's my impression that we all get all the full trauma pages. But several years ago, when Dr. Livengood first started as the trauma department director, we changed it so that the anesthesia team got the pages, but only came in if asked. So
okay.
all it would require is me, one, making sure that everybody on my team is getting those pages, number one, and then number two, changing our policy to reflect that you want us to come in for all of them. What percentage of full trauma activations do you think end up needing an intubation?
I would guess 10%. I mean, that's just a guess off the top of my head. Probably less than that even.
Yeah. So, yeah, I don't know if there's a way to narrow that down.
It probably, because we usually have an idea before the patient gets there. Not always, but we usually have an idea because our EMS is so good who's going to need an airway, or they're already trying to get one before the patient gets there. So we could be selective in that way and then give a heads up.
And I guess that brings up maybe you guys have talked with the EMS team about, or maybe Scott, if you've talked about getting them one of these tents, one of the intubation tents, or if they, could have it be adapted to their stretchers, or I guess they're the same stretchers, aren't they? No, they're not. Do they have the same IV pole inserts that we could use on their stretchers?
This is Chris Martinez. I don't think they do, Chris. I would have to check to be certain about that, but I don't believe that they're the same. I will just tell you that we have de-emphasized significantly intubations in pre-hospital patients, as well as unnecessary oxygenation, and trying to take care of people at scenes for cardiac arrest for the most part, again, without intubation, and going, even despite the things that we talked about initially, or you talked about initially, about using an eye gel with the seal, just because of more exposure with actual intubations in some of these patients. We've tried to simplify these things. Now, I know there are some EMS systems that are going straight to intubation, as they are in Eagle County, but I felt like it was probably better in our particular area to try to just minimize that. And if that patient needs oxygenation, to try to provide that with a non-rebreather, with a face mask over it, if at all possible, trying to meet the needs that way, bring the patient into the ED, and let, as soon as possible, if they look like they're going to need to have an intubation, let us take care of it there, because, as you know, it's much more structured. It's something that I'll look into further. I mean, it's a good suggestion. I hadn't really thought about it, because we've only been talking about using this sheet for the past week or so. So I'll look into that further. Thank you.
Well, I don't know if Dr. Roseberry's on the call or not, but one thing that we think about in the operating room with regard to the COVID intubation tent and that micro environment is that if you're using a non-rebreather face mask or oxygen inside that tent, you're going to get a high degree of oxygen inside that tent. And so if anybody does a procedure with cautery for any reason, which I guess is probably uncommon in the ER, but just to try to stave off some random bad event like a patient fire, the COVID intubation tent does create a fire risk if anybody's using cautery. Did anybody else have any comments or concerns or future directions we should take on any topics?
So I just had a quick comment and I just wanted to thank you for your recommendations with the high flow nasal cannula with the COVID patients. I mean, I think we were kind of ahead of the curve on that with a lot of the other facility or hospitals who, I mean, in the past, I think with the COVID specific patients, the early intubation has been thought to be the way to go. I think that thinking is now changing. And I think we've kind of been with the use of the high flow nasal cannula here that we've been doing. I think we've actually been ahead of the curve on that to some degree. So I did want to thank you for that. And
well,
as only
yeah, that was a lucky guess. I think primarily just taking into consideration something that I touched on before about just balance with the neutropenia question for that patient is just balancing the patient benefit right there and right then, right in front of you. Can you help this person or hurt them versus this more nebulous contamination risk? And I think it is easy to get carried away with the contamination risk concern and go into this deep, dark COVID hole. And it's hard to climb back out sometimes and remember that there's still just a patient in front of you that needs you to do a good job. So I think if I could, if that's one of my summary thoughts on this whole topic, is that despite all of this, we still just have to do a good job and try to have all of this COVID stuff start to feel normal to some degree. And so I appreciate all the ER docs contributing to this conversation. I think it's been good to collaborate with you on this, and it's been good to collaborate with the hospitalists, with Dr. Shah and Dr. Holmes and Dr. Goralka, sorting this out. And I've really enjoyed collaborating with the respiratory therapy team as well. And I appreciate all your input. And so thanks everybody for, I think, helping get this process to be what it is. All the discussions that we've had, all the emails that we've had have certainly spurred me on to learn more and try to come up with a process and put it on paper and communicate it with you guys. So I appreciate your time and consideration, inviting me to the ER Journal Club. So thanks everybody for attending. Any last comments?
Thanks, Dr. Beck. This is Becky.
Hi, Becky.
Let everyone know that we do have our tent setups completed, and we have multiple cut clear plastic sheets here in my office for many intubations. I would like to get with Dr. Martinez to reiterate some of our concerns for the ER staff to continue safe practice and some of the things that he mentioned later.
Yeah.
And anyone else that would like to contribute anything to collaborate to make our processes improved. Kim and I are sitting here, and Dawn, and we appreciate everybody's work on this to move forward. And the intubations from the ICU Dr. Beck did that I thought were real well using before we had our tent, but we did have plastic paper. So
Yeah.
I do. PAPRs, I do want to reiterate, the PAPRs are very hard to hear, so make sure you're planned very good with communication before everyone enters those rooms in those PAPRs. As most of you probably already know.
You know, I do want to specifically thank Kim and Bo and the RT team for all their efforts with managing the equipment and helping the anesthesia team and the ER teams get organized with the equipment. You guys really have been invaluable, and other members of your team randomly answering my phone calls to answer questions and talk through things like Dawn just did today to, you know, just talk about how you're using the one masks and things like that. So I really appreciate the team effort that all of this requires, particularly when we've got a patient in front of us. More than ever, we got to be collectively prepared and collectively make these emergent situations go as smoothly as we can have them go while keeping each other safe. So we really, you know, have each other's backs, and it's a time where the need for teamwork is as high as it could be, and higher than I recall it being previously in my career, except for those specific situations. Now it feels like almost every situation requires a heightened degree of communication, time, and energy. I know all of us have been putting in a lot more time and energy to even routine tasks. Any more comments? Well, thank you.
Thank you, Dr. Thank you very much. I'd like to echo the same. It's been a pleasure working with this RT team. They're extremely clinically strong.
Yes.
And have done an amazing job from the beginning to the end in preparation, and always in here looking for or researching everything. And now we're kind of on our outpatient kick for safe PFTs and treadmills for reopen post-COVID. So they appreciate everyone that's been involved with working with them, and we'll continue our process for improvement and stay on it, hopefully. Thank you.
Thank you, Becky. Thank you, Kim. Thank
Thank
you.
you. That was great.
Have a
Thanks
great
everyone for joining us. If we could have Dr. Gallagher, Balco, Glissman, Bernard, Ayers, myself stay on, but we'll let everybody else go. And thanks again for everyone joining us.
Thank you, Dr. Martinez, for working.
And Chris, thank you so much.
Thanks,
Back
Chris.
for your comments.
Thank
I
you.
totally agree with you. Teamwork.
Thanks, Catherine. All right.
Thank you. Thank you.
So Stevie, we were going to have a brief discussion amongst the 6 ED docs that I just named, if we can make sure that we have that taken care of.
Chris, this is Becky. If you don't need anything from Kim and I, we're sitting here, we'll hang up, but we just wanted to make sure.
We appreciate you guys joining us.
What was that?
Thank you. I said we appreciate you guys joining us.